Assalamu alaikum, my dear student. How are you all? I am fine too. I hope all of you are really in good mood and sound state of mind and enjoying our online live classes with very ease and enthusiasm. Today is our second class. I am really sorry to say that in my first class there were a lot of technical problems and it was not a good one, but today it will be very nice and interesting if you go through me from the very first to the very last part of my presentation. It is the continuation of very first class of mine, data interpretation. At the very beginning of our today's session, somebody sent a question to me that what is data? Simply data, nothing, just a collection of information, a system-wide information. So what are the importance of data interpretation in medical science? As you all know, whenever we manage a patient, at the very beginning we start from history taking, general examination, systemic examination, and on the basis of this general examination, systemic examination, patient history, we perform some investigation. This may be hematological, microbiological, pathological, radiological, and so on. And on the basis of this physical examination, finding, and these reports, there is data. We make a complete and concrete diagnosis of a patient. So data are really important. If we are not able to interpret this data meticulously, we will not be able to diagnose this patient meticulously. So, dear student, data are given in your final profession examination, in your board examination, and you will find also in your OSPE examination. And whenever you will face long case, you have to ask various type of question on the basis of data. So data are really important. So let's start. I am Mama Dr. Ruhul Amin. Types of data. Said earlier, hematological, biochemical, microbiological, and histopathological, and various type of data, so on. These are very prototypical reports, data. If we look from the very beginning to the end, like here is name, age, sex, and there are a lot of hematological data. Later we will discuss it meticulously. What will be the diagnosis of this report? We will discuss it later. So whenever we will find the data, some points should be noted, like name, age, sex, date, and hematological, or if available other parameters. So what is the importance of age? If you look towards this slide, you will find that multiple myeloma, Hodgkin lymphoma, non-Hodgkin lymphoma, CML, CLL, myelodysplastic syndrome, etc. Look, multiple myeloma peak age is 60 to 70 years. In case of Hodgkin lymphoma, peak age is 31. In case of non-Hodgkin lymphoma, median age is 65 to 70. In case of CML, this chronic myelocytic leukemia, median age is 55. And chronic lymphocytic leukemia, median age is 65 to 70. And myelodysplastic syndrome, 73. So age is very important. To diagnose a disease, we have to look towards age because age can guide us to diagnose a patient very easily. Sex. What are the importance of sex determination? Look, in case of ITP, iron deficiency anemia, females are mainly affected. Male also may be affected. In case of multiple myeloma, on the other hand, males are affected. Lymphoma, hemophilia, males are affected. So, sex determination can guide us to interpreted data. Some hematological point, that is hematological parameters, hemoglobin percentage, erythrocyte sedimentation rate, total WBC counts, differential counts of WBC like neutrophil, lymphocyte, monocyte, eosinophil, myeloblast, platelet count, bleeding time, coagulation time, MCB, MCHC. And if we know the normal reference ranges, we can then easily find out the any pathology, that is any abnormality. Hemoglobin percentage or the range of hemoglobin in case of male 130 to 180 gram per liter, female 115 to 165 gram per liter, erythrocyte sedimentation rate, male 0 to 1 millimeter first hour, female 3 to 50 millimeter first hour. Total WBC count. Look here. Here also hemoglobin and in case of erythrocyte sedimentation reference ranges, male female is different. So interpreting a data, we should look towards the sex of a patient. Total count, neutrophil differential, lymphocyte, and abnormal cells like myeloblast, less than 10% total WBC count. Platelet count, as we all know, 150 to 350. So what is 10 to the 9? 10 to the 9 means 1000. 150 to 350,000 per liter. Red cell count, look towards again, male female different. Bleeding time less than 8 minutes. Prothrombin time, hematocrit, that is packed cell volume, male female different. 0.40, 0.54 is the ratio, or percentage 40%, 50%, 54% in case of female different. Mean cell volume 78 to 98 femtoliter and reticulocyte count. So if we know all the normal parameters, we will be able to detect any pathology if present. This is the previous one. Look towards, if we look towards the very beginning to the last, name means that is female, female, age 20, younger age. Hemoglobin percentage 12.5 gram and virtually normal. ESR 30, almost normal. Total count, WBC count 6,800, it is almost in a normal range. Neutrophil 65%, lymphocyte 30%, monocyte 2%, eosinophil 3%, basophil nil, and immune cell nil. platelet count 30,000. Bleeding time not done, coagulation time not done. So what will be the diagnosis of this patient? If we look very meticulously, if there are any abnormality, yes, there is abnormality here, thrombocytopenia. So if we look systematically, thrombocytopenia. Whenever we found a thrombocytopenia, we have to go through likewise, like in this way. Thrombocytopenia, then we have to look towards hemoglobin and WBC level. If abnormal, we have to think leukemia, lymphoma, or any other diagnosis. If normal, then have to look towards the RBC morphology. If it is normal, that may be our diagnosis may be ITP or TTP. And now if we study it side to side, Miss X, age 20, female sex, thrombocytopenia. Here is a thrombocytopenia. So if we look towards hemoglobin and WBC count, hemoglobin virtually normal, WBC count almost normal. So hemoglobin and WBC count normal, no abnormality here. So it may not be a case of leukemia, lymphoma. On the other hand, if we look towards this normal RBC morphology, although we have to examine pixel volume or MCB, MC, HMCAC, lot of parameters to see the RBC morphology. Although these parameters are not available here, think that it is normal. So RBC morphology normal. So it may be a case of ITP and TTP. So whenever we will find a platelet count less than normal and all other counts are normal, no abnormality, then this is termed as isolated thrombocytopenia. Isolated thrombocytopenia. So whenever we will find isolated thrombocytopenia. So this may be a case of ITP, idiopathic thrombocytopenic purpura. Again, if we go through largely to evaluate a case of thrombocytopenia, hemoglobin count, if we found abnormality, leukemia, lymphoma, then we have to perform bone marrow examination, lymph node biopsy, or immunohistochemistry. So many other tests we can perform. And if it's normal, then we have to look towards peripheral blood smear, that is PBF. If peripheral blood smear finding normal RBC morphology, then we look towards the platelet if it is normal or increase its size. So RBC morphology, platelet size may be normal or increase. We can come into inference that this may be a diagnosis of ITP. This may be due to drug induced or immune. Okay. Now we should go through what is some definition, some parameters meticulously. Without knowing this kind of parameter, it is very hard for one to explain a complete blood picture. MCB. What is MCB? Blood test measures the average size of our red blood cells. If our red blood cells are too small or too large, that means that MCB will guide us the size of RBC. There is morphology of RBC, and it could be a sign of blood disorder such as anemia or a vitamin deficiency. So MCB low, microcytic RBC, MCB high, macrocytic RBC. So what are the causes of microcytic RBC or macrocytic RBC? Microcytic RBC are four causes: iron deficiency anemia, thalassemia, sideroblastic anemia, anemia of chronic diseases. On the other hand, macrocytic RBC, vitamin B12 deficiency, folate deficiency, liver disease, hypothyroidism, hyperlipidemia, and pregnancy, and so on. So, in your final professional examination, these causes of microcytic anemia, microcytic RBC, microcytic anemia are asked in various parts of your examination. You should commit to memorize it. So, if we look towards this scale, look in the left hand side, heme is deficient, so MCB is less. Heme less, weight less, so MCB less. In reverse, in the left hand side, look. So, what may be the cause of decrease heme? How heme causes decrease MCB, or how it may cause increase MCB? Look at the structure of a heme: polypeptide chain, 4 polypeptide chain, iron, and heme. So those RBC have more polypeptide chain, they have more MCB, and those RBC have less polypeptide chain, less iron, less heme, they have less in size, and they have less MCB. Look again. Yeah, no, less heme, less MCB. So what may be the cause of less heme? Iron deficiency anemia, thalassemia, cerebral-spastic anemia, anemia of chronic disease. So what will be the cause of macrocytic mechanism of macrocytic RBC? In almost all of these causes, whenever the body uh, lipid concentration are increased in the body, RBC have a lipid bilayer cell membrane. They will take up the more and more lipid and will increase the mass and thus increase their MCB. This is the second scenario, second report. Miss X, that is female, 18 years, is X female. What are the abdomen here? Yes, 80,000 platelet count. So this may be a case of ITP. Look towards here. If we first go through from the very first to the very last: name, age, sex, hemoglobin percentage 7.5, it is deficient, less, ESR 50, that is increase, total WBC count increase, neutrophil decrease, lymphocyte lower limit normal, monocyte eosinophil, myeloblast, myelocyte, and platelet count. So what is the diagnosis of this report? Is it ITP? Is it ITP? I think it's not ITP, because as we know, we have to find isolated thrombocytopenia to diagnose ITP. If you look towards here, anemic patient, hemoglobin percentage is decreased, ESR increase, and there are also myeloblast 45%, myelocyte 5%. So it is not isolated. So this may be another diagnosis, not ITP. So we have learned that to diagnose the ITP, we have to find isolated thrombocytopenia. If there are any other abnormality in your reports, we have to diagnose otherwise. We have another two reports. Reports 3, number 3. Look, what is the diagnosis of this number 3 slide? And number 4, look, you will send the answer of these two last slides to my Facebook inbox, and if you have any query to me, please inbox me in my Facebook without any hesitation. But be careful, don't be hesitate to find this kind of faces, but answer may be really very easy. Yes, this may be a cat. Now we are turning to another report, the thyroid gland. As we all know the anatomy, physiology and pathology of thyroid gland, we will have just glimpse of thyroid gland. This is the anatomy of thyroid gland. Look, this is the anatomy of thyroid gland with blood supply and venous drainage. It is very important for us to know the blood supply and venous drainage of thyroid gland, because thyroid gland has a enormous blood supply. Any problem, any surgery difficulty here, any problem here will create a lot of problem in our body. As we know, the synthesis of thyroid hormone and the physiological function of thyroid hormone really a great deal. Thyroid hormone functions over the various tissues on our body. If you look towards here, hypothalamus, pituitary gland, thyroid stimulating hormone, thyroid gland, T4, 3T. If we look, so how thyroid hormone is synthesized? First, there is a stimulating hormone from the hypothalamus, TRH. There is thyroid releasing hormone is secreted from the hypothalamus on the anterior part of the pituitary gland. So from on the stimulation of TRH, anterior pituitary will release TSH, thyroid stimulating hormone, and thyroid stimulating hormone will act on thyroid gland, and in this way it will synthesis T4, 3T, thyroxine and triiodothyronine, and T4 also may be converted into T3, and in the tissue mainly T3 is functioning. Look, again this is thyroid regulation, hypothalamus, thyroid releasing hormone, anterpituitary, thyroid stimulating hormone, and the thyroid gland T3T4. If we know the basic physiology, if TRH is increased, TSH will be increased, T4 and T3 will be increased. On the other hand, if T3 and T4 are decreased, but TRH and TSH increase. So there are two different formula. As we know, when brain gland is involved, it is primary disorder. When gland is affected by the outside, it is secondary disorder. So in case of secondary disorder, secondary thyroid disease, TRH will be increased, TSH will be increased, thyroid hormone will be increased. All of the three things will be increased in case of secondary causes. But in case of primary causes, T3 and T4 will be decreased, and it will act on the hypothalamus that we are less, please synthesis more TRH, more TSH. In this way we will synthesis more T3 and T4. So in the primary disorder, T3 and T4 will be decreased, but TRH and TSH will be increased. There are a lot of problem regarding the thyroid hormone regulation. So what are the thyroid function test? Thyroid stimulating hormone, T4, T3, mainly free T4 and T3 are measured. This is the very best prototypical hormone examination report that will be given in your final professional examination. If you look towards your very meticulously from the very first to the last, name Mrs. Rumi, that is female, and younger age. And as we all know, the thyroid gland is more vulnerable in case of female. T3 increase, T4 a bit of increase, TSH decrease. So what will be the diagnosis of this case? Yes, you are right. And if you go through in this way, here T4 is increase, T4 increase, TRH decrease, so TSH will be decrease. So what may be the diagnosis? Yes, thyrotoxicosis. So is it primary or secondary? It is primary. So understanding this thyroid hormone regulation will help us to diagnose the case of thyrotoxicosis. There is hyperthyroidism, hypothyroidism, and lots of clinical problems regarding the thyroid hormone regulation. Now we are shifting to the CSF study. CSF analysis. As we know that CSF is very important for final professional examination. In your written examination, in your OSP examination, in your board examination, you will be asked regarding meningitis. So diagnosing meningitis and describing a CSF analysis is very much important. So we should know the basic anatomy, physiology, and pathology of CSF circulation, including brain and meninges. This is a very nice picture of CSF circulation. Yes, here is lateral ventricle. Here is third ventricle. Yes, fourth ventricle. And CSF circulates in this way. And here is coronary plexus. CSF is synthesized here, and it will then pass to the lateral third ventricle through interventricular foramen. And from the third ventricle, you will again pass into the fourth ventricle through cerebral aqueduct. Look, cerebral aqueduct. And after that, you will pass and nourishing the brain through cisterna magna and cisterna and circulating the whole brain. Sagittal sinus, subarachnoid space, and durameter. It is durameter. Very importantly, if this CSF circulation is blocked anywhere by the infection, inflammation, trauma, meningitis, there will be increased CSF pressure, and it will cause hydrocephalus. And the CSF fluid is always sterile. Whenever any pathogen, any virus, any bacteria, any blood, or a malignant cell enter into the CSF, it will cause a lot of reaction. that is, it will cause meningitis. To explain a CSF report, we have to understand the basic microbiology and pathology of cerebrospinal fluid. Here is our oropharyngeal site from where a infection can enter into the CSF. Various way a pathogen can enter into the CSF, but here is a oropharyngeal colonization of bacteria and it will enter into the CSF circulation. Look, mucus, epithelium, blood and CSF. Here is a pathogen entering the CSF. So in case of interpreting a CSF report like that, we have to know some basic microbiology. In your final professional examination, you will be given a bacterial a CSF report or a viral CSF report or a mycoplasma, that is, or a mycobacterial, that is tuberculosis. So in case of purely bacterial infection, whenever any bacteria will enter into the CSF circulation, it will cause inflammation. So a fever will be fever, headache, neck stiffness, and if it is Neisseria meningitis, there will be a lot of purpura and petechiae in the whole over the body. So what will these bacteria, what will affect in CSF? If we study the CSF, we will find that neutrophilic leukocytosis, because normally in CSF is a sterile port, but here we will find neutrophilic leukocytosis and protein level will be increased and glucose level will be increased. And in case of tuberculosis, when a microbe are colonized in this in the various part of the body and entering the CSF circulation, it have a cell wall. So bacteria has cell wall, that is protein. So if we study the CSF, we will find increased protein. For the survival of the bacteria in the CSF, it will take the glucose of CSF. So glucose concentration will be decreased. And at the same time, in case of tuberculosis, leukocytosis, but here we increase lymphocytic. But in case of bacterial, it is neutrophilic leukocytosis. On the other hand, if bacterial invasion occur in CSF, the similar reaction will occur, but there will be less protein content, not slightly increase. Glucose concentration almost normal, and there will be leukocytosis, but not like that of mycobacterial or pure bacteria like Neisseria meningitis, pneumococcal, or any other bacteria. So if you keep in this point in our mind, so it will be very easily we can explain a CSF report. Viral, bacterial, pure bacterial and mycobacterial, this is tuberculosis. Yes, if we study this CSF examination report from the very beginning to the last, name Mr. X, age 25 years, sex female. So color strong, appearance clear, sediment nil, total protein highly increased, sugar decreased, chloride measured, total count, differential count, polymorphs 5%, lymphocyte 95%. So if you think that what is the diagnosis of this CSF report? Yes, you are right. As we know, in case of mycobacterial infection, total protein is increased, sugar reduced, as and lymphocyte is 95%. So this is diagnosis of tubercular CSF examination report. On the other hand, if it is purely bacterial, poly polymorphs will be highly increased, lymphocyte will be slightly increased. The remaining part a bit of similar. And in case of viral, total protein will not so high, slightly increase, sugar almost normal, and differential count lymphocyte will be increased in case of viral disease. So I think it is very important for all of us to know the data interpretation, like complete blood picture, hormonal report, CSF examination report. We have another reports like urine examination. In case of urine examination, you will find pus cell or hematuria. Like that. Yes. Look, RBC count here 2240. So this may be a urine report of hematuria. This is your homework. You will go through the box and know the evaluation of hematuria. It is very easy. So all of the report that will be encountered in your final professional examination has been given. Just go through the books and evaluate it. If you have any query, just send your question to my Facebook inbox. Feel free to send it. I will reply, of course. Thank you very much. Thank you very much. Hope we will see you again.